joining us today for the Best Advice Guide, Recovery-Oriented Mental Health and Addiction Care in the Patient's Medical Home. My name is Uyan Ta. I'm a Program Manager for the Prevention and Promotion Initiatives at the Mental Health Commission of Canada. We're very excited to have you all today join us on this webinar. So just before we get started, we're going to go through a few housekeeping items. So we invite you to first send questions or comments using the Q&A feature on the right side of your screen. There's also a way to download the slides. So if you see, there's a box that says Files. You can click on it to download the PowerPoint if you want. And we encourage you, when you send in your questions, to select all panelists, so all the questions go through myself and the presenters. So I'll be your host today for the webinar and the moderator for the session. And to let you know, this webinar is also being recorded, and it will be posted on the Mental Health Commission of Canada website in the webinar archives in about 2 weeks. And we will also be posting the slides from today's webinar on the website. Also, due to our large number of participants today, we have muted all of your phones. And if you can make sure to also mute your audio to be sure that there's no technical problems, that will be great. All right, so let's get started. So today we're really excited because we have 3 presenters, and I want to take some time to introduce you to the presenters today. From the Mental Health Commission, we have Brandon Hayes. Brandon started his career in public health consulting, environmental behavior, and youth well-being research. He has conducted mixed method evaluations of student-led mental health conferences and well-being outcomes for refugees and newcomers. Additionally, Brandon brings significant experience in mental health and addictions, not only as an addictions counselor, but as a program consultant as well. So he uses his skills in implementation science, knowledge exchange, and program evaluation to identify and address system gaps in Ontario mental health and addiction sector. To this end, he was a co-author of the 2018 Ontario Public Health Standards for Mental Health Promotion. He holds a master's degree in community psychology. We also have 2 external guest speakers. We have Dr. Victor Ng, who is a consultant family doctor practicing in family and emergency medicine in Toronto. He is a faculty member at both the University of Toronto and Western University, and his academic interests are primarily in medical education with teaching responsibilities at the undergraduate and postgraduate level. He currently serves in a leadership role as the physician advisor in the Division of Continuing Professional Development and Practice Support at the College of Family Physicians of Canada. So in the past, Dr. Ng has served on the CFPC Board of Directors. He has also sat on the editorial advisory board of the Canadian Family Physician Journal and was a member of the National Committee on Continuing Professional Development. At the World Organization for Family Doctors, he chaired the Special Interest Group on Emergency Medicine and co-led the development of the global CPD standards. Finally, we also have Shalene Jones joining us as a guest speaker. She has worked in the fields of peer support and mental health for over 20 years, holding leadership positions with peer-led organizations such as the BC Eating Disorders Association, Lang House, and Peer Support Canada. She was recognized for her contribution to mental health with the Inspiring Lives Award from the Mental Health Foundation of Nova Scotia and sits on the Minister of Health Mental Health Advisors Group. Shalene manages anxiety and has recovered from an eating disorder. As a parent of a child with mental health concerns, she has learned about the challenges of our mental health system from a different perspective. Her experiences led to her commitment to mental health system reform and her belief in the power of peer support. Shalene is currently the Executive Director for Eating Disorders, Nova Scotia. So thank you for our speakers for being available today for the webinar. So very quickly, on the slide, you will see today's agenda. So our goal is to begin with giving you some information on who we are, the importance of recovery-oriented practice, as well as a background on the Best Advice Guide. Then we're going to jump in a more interactive interview session with Shalene and Victor, who will be giving us their perspective as a patient and physician on the Best Advice Guide. We'll finish with a Q&A period, so again, please don't hesitate to send in any questions through the Q&A box. So about the Mental Health Commission, if you're not familiar with us, we are a pan-Canadian nonprofit organization. We were created in 2007 in response to a Senate committee tasked to study mental health, mental illness, and substance use. We lead the development and dissemination of innovative programs and tools to support the mental health and wellness of Canadians. We also support federal, provincial, and territorial government, as well as organizations in the implementation of sound public policy. And finally, we also consult widely with people with lived experience and their families to inform its work. About the College of Family Physicians of Canada, the organization is the voice of family medicine in Canada. So currently, CFPC has over 38,000 members and is responsible for establishing standards for the training, certification, and lifelong education of family physicians, and for advocating on behalf of the specialty of family medicine, family physicians, and their patients. CFPC accredits postgraduate family medicine training in Canada's 17 medical schools. I'm going to now pass the mic to Dr. Ng, who will give you a bit more information about CFPC.
Great. Thanks there, Ewan, and thank you to the Mental Health Commission for having me and family physicians represented on this webinar. And greetings to all of you who are listening. So the Patient's Medical Home is one large project that the College of Family Physicians has undergone in the last few years. As previously stated, the CFPC, the College of Family Physicians of Canada, is essentially the national voice of family medicine, representing 38,000 members. We also represent our trainees, our residents, and also our medical students as well, who are interested in family medicine. So the Patient's Medical Home essentially is our vision for how family medicine and family practice should look like in Canada. And looking at how family medicine and their practices engage with their community, engage with their patients, and looking at how to best meet their primary care needs through these collaborations. Maybe next slide there, Ewan. So within the Patient's Medical Home, we have undergone the development of several Best Advice Guides. So the Best Advice Guides are basically supplemental and supportive documents that we have developed both for our members, our family physicians, but also external stakeholders and government representatives, such as some of you on the call, to look at how family physicians can actually develop their patient's medical home in a way that can care for whether it's specialized populations or in specialized areas, such as how do we engage with electronic medical records in the support of a patient medical home. So how do we manage chronic pain in such a way that's patient-centered in a medical home. And most recently, this topic that we'll be talking about today, which is the recovery-oriented model and how that functions in the patient's medical home. That is what we've done with this Best Advice Guide to showcase this framework. So some of the background on this guide, so we were quite excited that the College of Family Physicians, along with the Canadian Psychiatric Association and the Commission, were to be able to collaborate on this work. It's been 2 to 3 years of very fruitful and very engaging shared work that we've done on this guide, and we're very excited to showcase this to you. And essentially, it's not really inventing a new idea, but essentially trying to deconstruct an idea that has already been in circulation, the idea of the recovery-oriented approaches or the recovery-oriented model, but how do we actually showcase this, and how do we actually implement this through the patient's medical home, and how do family physicians, in this case, engage with their patients through this sort of an approach. So this guide is one mechanism for us to look at how this can be operationalized and achieved in the community between family physicians, their respective healthcare teams, and along with their patients.
Thank you, Victor, for this overview. I will now pass the mic to Brandon, who's going to give you an overview of what is recovery-oriented practice, as well as dive in more deeply into the Best Advice Guide.
Thanks, Julian. As Victor mentioned, this project represents one more exciting step in supporting healthcare providers in responding to the needs of people living with mental health problems and illnesses based upon the principles of recovery. But before we share with you further details about this initiative, I wanted to give you a bit of historical background and context first. As many of you know, recovery has served as a foundational organizing principle guiding mental health system transformation efforts over the last decade or more. Recovery emerged from the psychiatric deinstitutionalization movement and the broader civil rights movement of the 1970s, especially in the United States. In Canada, the voices of lived experience began to emerge more strongly during the 1980s and then began to share their often difficult and sometimes demeaning experiences in mental health institutions. During the 1990s, recovery concepts from the United States began to become the focus of these voices as a way of taking back their power. Some key concepts that emerge from these conversations include getting professionals to view people with lived experience beyond their diagnosis, to recognize and build on their inherent strengths, as well as their potential contributions to treatment, service design, service delivery, and evaluation. After much consultation with stakeholders, the Mental Health Commission has come to define recovery as living a satisfying, hopeful, and contributing life, even if there may be ongoing limitations for mental health problems and illnesses. This is the definition that was first used in the Mental Health Commission's framework for a mental health strategy, which was called Towards Recovery and Well-Being in 2009. This framework, and especially the recovery principles it articulated, were the foundation for developing Canada's first and only mental health strategy, which was released in 2012. There are also two pillars to the recovery concept. One, that each person's path is unique and that everyone has the right to choose what their journey of recovery looks like. Two, the second pillar recognizes that many different factors influence mental health and well-being, whether they be biological, psychological, economic, social, cultural, or spiritual. In addition to recovery being foundational to the mental health strategy, it also made specific recommendations for increasing the uptake of recovery in settings providing mental health care. Under strategic direction number 2, there were 2 specific recommendations around this, including Recommendation 2.11 to implement a range of recovery-oriented initiatives in Canada, including the development and implementation of recovery guidelines, and Recommendation 2.12, which was to promote the education and training of mental health professionals, and other service providers in recovery-oriented approaches. These recommendations were the impetus for developing the recovery-oriented guidelines, which were released in 2015, as well as the Best Advice Guide, Recovery-Oriented Mental Health and Addiction Care in the Patient's Medical Home, which of course was released this past fall and is related to the second recommendation outlined in the strategy. So the guidelines for recovery-oriented practice were developed in partnership with key leaders who are working to advance recovery-oriented approaches. The core of the team included people with lived experience, professionals, a retired psychiatric hospital CEO, all of who were led by Dr. Howard Chodos. The team exhaustively examined the state of knowledge and research through literature reviews and engaged with Canadian and international recovery leaders and champions. The guidelines were and remain to this day the only comprehensive Canadian reference document for understanding recovery and practice and promoting a consistent application of recovery principles across the country at a policy, program, and practice level. With attention to core principles, values, and knowledge of recovery, the guidelines sought to complement existing professional standards and competency frameworks such as the CanMed's 2017 framework, which guides the practice of family medicine. This, of course, is a target audience integral to the launch and the content in the Best Advice Guide. By framing the guidelines in this way, the recovery guidelines sought to help transform culture and practice in a way that people living with mental health and addiction problems and illnesses get the care they need and deserve. The guidelines for recovery-oriented practice are additionally grounded in values and principles that recognize the expertise and strengths of people living with mental health problems and illnesses, as well as their families. It recognizes the important role that practitioners play in supporting recovery by working in partnership with people with lived experience and providing access to professional expertise. It also recognizes the diverse perspectives on wellness and mental health that exist across cultures and traditions. And it also additionally recognizes the need for more multi-sectoral and collaboration approaches to support recovery and to promote systems change. This last point, multi-sectoral partnerships, is really important given that the application of recovery principles are really important for anyone providing or receiving any kind of mental health service, regardless of the setting or the type of mental health problem being addressed. For reasons we'll go into shortly, family physicians, of course, offer one exciting and important avenue for delivering recovery-oriented care, as Victor mentioned. So there are 6 dimensions of recovery that are outlined in the guidelines, and each have their own chapter specifically devoted to these dimensions. Each of these dimensions are also the subject of previous webinars we've done in our recovery webinar series. This includes creating a culture and language of hope. It includes recognizing that recovery is personal, that it occurs in the context of one's own life, that it needs to respond to the diverse needs of everyone living in Canada. It necessarily involves working with and collaboration with First Nations, Inuit, Métis peoples, and it recognizes that fundamentally recovery is about transforming services and service systems. As mentioned, each of these 6 dimensions of recovery are really discussed and framed in terms of their core operating principles, values and attitudes, knowledge, skills, and behaviors that align with recovery-oriented practice. Many of these dimensions are also naturally applicable to the recommendations that are outlined in the Best Advice Guide. Some noteworthy examples include using strength-based language with clients, viewing clients as whole persons beyond their diagnosis. It also is about having service providers really encourage and promote the autonomy and self-determination and choice of those receiving care. It is about building partnerships with a broad array of services and service providers and supporting clients' connection to their families as well as to their life in the community, such as social support networks. It is also about adapting principles that are friendly, safe, and welcoming for many different kinds of people that are getting and receiving care, and about exuding cultural competence. Aligned with the First Nations continuum framework on well-being is about facilitating hope, belonging, meaning, and purpose, recognizing historical power imbalances that may exist between service providers and service users. It's about promoting full citizenship of people and life in their community beyond their interactions with the formal health care system. It's about seeing persons with lived experience as partners in their own care and balancing and training up on the different kinds of expertise and knowledge that are available in the room and between the interaction between service providers and service users. And it's also about, once again, promoting partnerships between service providers. And with that, we increasingly began to recognize the importance of increasing the uptake of recovery practice in primary care. This really stems from the fact that 2/3 of all individuals seeking help for mental health and addictions problems and illnesses do so through family physicians, who in many cases are their first and only source of contact. Family physicians also serve as a critical care and care coordination role for this group. Many feel comfortable talking about their mental health needs and feel the level of care provided by family doctors is enough to meet their emotional and psychological needs. Yet family physicians do not always feel this way. So as Victor mentioned, the Mental Health Commission looked to the College of Family Physicians as well as the Canadian Psychiatric Association, who has been collaborating through a collaborative working group on shared mental health care for over 2 decades. Among their central aims, the shared mental health care group sought to better integrate mental health services within primary care settings and continues to look to find ways to improve the quality of care of those living with mental health and/or addictions, problems, and illnesses. And in 2017, the Commission partnered with the shared working group to better explain recovery in the context of the CFPC's patient medical home and collaborative mental health care work. This led to the co-production and release of the CFPC's Best Advice Guide for Recovery-Oriented Care in the Patient's Medical Home, which was developed with the guidance of this collaborative working group. The document was released at the Canadian Mental Health Association's Mental Health for All conference, which took place in Montreal this past October. In addition to its core recommendations, the Best Advice Guide covers general statistics on mental health and addictions prevalence rates in Canada, the role of primary care in mental health, discussions on recovery, and it additionally includes a list of resources in the appendix. To make this resource possible, in 2017, the Commission conducted a cross-mapping and crosswalk exercise, which really looked at overlapping similarities between the notion of the patient's medical home and recovery. Some of these similarities between the two concepts are also found in the appendix of the Best Advice Guide. And these really include things like encouraging shared decision-making, optimizing the satisfaction, functioning, and meaningful participation of service users in service planning, fostering team-based care and partnerships, ensuring timely access to care, ensuring continuity of care regardless of age or developmental stage. It is about continuous workforce development and training, which includes persons with lived experience and service users, and fostering continuous quality improvement. And all of this led, of course, to what we have before you today, the Recovery-Oriented Mental Health and Addiction Care in the Patient's Medical Home Best Advice Guide, and all the recommendations that are contained within it. So recommendation number 1, using strength-based language when communicating with patients in order to combat stigma and create safe spaces where patients feel comfortable discussing their treatment and care needs. Appendix B of the guide also discusses specific examples of recovery-oriented language and what recovery-oriented language looks like. Recommendation number 2, to facilitate patient choice and share decision-making in practice by co-developing personal care plans with patients. Recommendation number 3, involving, where appropriate and with permission, families, friends, and community members in care plans. This is also about recognizing the central role that family caregivers play in supporting patients, and that they actually can and in many cases should be included in appointments and in the development of treatment plans. Recommendation 4, enhancing clinics operations to better accommodate patients with mental health and addiction problems and illnesses. This can include things like adding signs in the physician's office that state that discussing mental health and addictions problems and illnesses is part of their job. It can include offering a check-in or a standardized intake form that includes questions on mental health. It can also include supporting colleagues in changing their learned behaviors to create a stigma-free environment. Recommendation number 5, providing education and training opportunities for physicians and staff and ensuring training involves people with lived experience. This recommendation is about engaging family physicians and allied health professionals in learning opportunities to increase their own comfort with and knowledge of recovery-oriented practices. To support these goals, the appendix has a list of continuing education programs that are available for physicians and colleagues regarding mental health and addiction care, as well as another list on clinical practice guidelines for a variety of mental health and addiction problem and illnesses. Recommendation number 6, this recommendation is about physicians becoming more familiar with community supports and services and connecting and referring patients as needed, and this can be done by physicians doing things like developing a resource list of supports that are available in their local communities. And recommendation number 7, which is about where possible and appropriate, physicians addressing co-occurring mental health and physical health problems that may exist by integrating screening, treatments, and supports. This recommendation can be realized through things like routinely including 1 or 2 questions about mental health and/or addictions, problems, and illnesses in various appointments with patients to help normalize mental health check-ins in practice and to reduce stigma. So now I'm going to hand it over to my colleagues about patients' and physicians' perspectives on the Best Advice Guide.
Thank you, Brandon, for summarizing key points for the audience. Before we dive into the more interactive session, again, I just wanted to reiterate, if you have any questions so far or comments, make sure to use the Q&A box to let us know. If you would like to have a bit more information on anything that has been addressed up to now. So now we want to turn the table and take some time to discuss with Shalene and Victor, as they will be sharing their experiences and advise us on how healthcare providers, patients, and families can use the Best Advice Guide to promote health and well-being for the patient. So my first question for both of you is, from your perspective, why is it important to see recovery-oriented practices for mental health and addiction incorporated into primary care? So imagine a visit to your family physician, from either getting to the office right through leaving. How would recommendations from the Best Advice Guide change your experience of providing or receiving care? So if you can talk a bit about how your clinic, either as a physician or a patient, look like after the changes for the audience, that would be wonderful. So maybe we'll start with Shalene, who can give us the perspective from a patient.
Great, thanks. Hi, everyone. Nice to be involved in this conversation today. I was going to see you all, but of course we can't see each other. So I think what really resonates for me about all this work, and thanks, Brendan, for doing such a thorough job of giving us the whole background, is that, incorporating recovery-oriented approaches, it works. It makes a difference for those who are walking in through the doors, who are receiving care, and it results in better outcomes. So we know that this is, a shift and additional work and a new approach for some of us. But it results in building a real sense of collaboration, in a sense that we're working together with our physician as a team in our care or the care of our loved ones. And that goes a huge way to helping us access the care that we need, to follow care that's been developed for us. And it really helps us, I think, as folks with lived experience, addresses that issue of stigma that so many folks experience when considering reaching out to a care provider. So I think it can be really transformative when it's implemented.
Thank you, Shalene. Victor, what do you think about the Best Advice Guide, and from your perspective, why is it important?
Great, thanks you, and thanks Shalene for the good start to getting the question. I mean, to be honest, I mean, I think most of my responses to this is very similar to Shalene, because I mean, I think whether we talk about it from a physician perspective or from a patient perspective, I mean, it really, to be honest, should be probably from the same or similar perspective, because we're both trying to work together to achieve the same goal, which is essentially enable the patient or the person within the community to be able to function to the best of their ability, regardless of whether they have a mental health condition or whether they have diabetes or whatever illness that they may or may not have. So I think in many ways we're working towards the same goal. I think within the Best Advice Guide, some of the pertinent information that I take away from it, and I would encourage other family physicians to take away from it, is the idea of the language use. I think the strength-based language is quite important, and I think sometimes we often don't think that we are actually stigmatizing, I don't want to say patients, but people in general, and we sometimes probably don't mean to, but I think having that very explicit recommendation to use strength-based language, and also within the Best Advice Guide with some actual examples of how language that we should be using and how we actually can frame some of the conversation with our patients and some of our clients. I think that's very important. And then also the other recommendation I think I would think will resonate with a lot of our colleagues is the idea of ensuring that our clinics and our office staff are also aware of mental health and mental illness. Certainly there's courses that the Mental Health Commission, such as the Mental Health First Aid and courses such as that I'm sure Brendan and other colleagues at the Commission can speak more about. But, certainly within our patient's medical home or our clinic environment, it really is a team and interprofessional environment that we need to ensure that every team member is able to provide a similar approach and a similarly welcoming approach to our patients that come to us, because ultimately it is the journey for the patient, and ultimately we're all there to support their own recovery, whatever that may look like to that individual patient.
Those are great points, Victor. I 100% agree with you. Just the environment when you are dealing with overwhelming feelings of anxiety and depression, et cetera, sometimes accessing care can be really challenging because we have to, many folks have phone anxiety or, to have challenges like being in public at a point where you're in crisis. And so being able to walk into an environment that conveys a sense of welcoming and a sense of safety, just having, the first person you see, having the receptionist smile, something as simple as that can be tremendously helpful at reducing any feelings of discomfort or unease. And also, to Victor, again, your comment about the language, that's, again, so crucial. And I love the tips we have in the document that you maybe have seen that give some examples of how to use person-first language. And it's such a subtle thing, but when we change the way we talk about mental illness and we talk to people with mental illness, it conveys that sense of caring, that sense that the person is really first. So, phrases like, Jane is not compliant, that puts the onus on the person, and using terms like, the treatment has not yet worked for Jane, or phrases that denote that it's not the person's fault when they're really struggling. Again, that goes a huge way in creating that sense of hope and optimism for recovery.
Thank you both for sharing your perspectives. Victor, in terms of when we talk about skills, practices, or competencies, what do family physicians need to bring that are already well aligned with the recovery-oriented practices or recommendations outlined in the Best Advice Guide?
Sure. So that's another great question, Ewan. I think part of the benefits of family medicine really is at the core is the comprehensiveness and the continuity of care, and also being able to care for multiple family members. So I think that allows the family physician to have a different perspective just by the virtue of their working environment and their context to be able to understand perhaps why the patient is feeling the way that they're feeling, and also what potential I guess in some ways non-clinical supports that they need. Is it something that has to do with finances? Is it something to do with mobility? Is it something that is temporary and may resolve? Is it something that can be helped with other caregiver supports, or maybe all of a sudden there is a lack of caregiver support because they're going through some sort of a separation or there's been a death in the family. So I think those are all skills and also abilities that the family physician can bring to the care of the patient just by virtue of where they work. I think the other benefit just from a training perspective for family physicians is that in the last 20 to 30 years, we have been training family physicians in the patient-centered clinical model. So essentially it's a bit of a paradigm shift, as we know, from a quote-unquote doctors know best perspective to one that we're working with the patient to ensure that we're journeying down this path together. And I think that's been a very nice and very rewarding paradigm shift, both for the clinician and also for the patient, where we may say, you need this medication, but the patient may say, well, unfortunately, I can't afford it. Is there another option? And together we kind of work through that to ensure that the patient is getting the most benefit that they can from their visit, but also to be able to inject some of that expertise that the family physician and the respective healthcare team can bring. So I think some of those elements that we've included in our training programs have really benefited and does integrate quite well with the recovery model. The other element I'll speak to is the competencies that are laid out in the training program for family physicians, and certainly mental health and mental illness is certainly at the top of that list. And when we know that patients with mental health and mental illness are quite ubiquitous in society, and as such, we need to ensure that our trainees, our residents, our medical students, and ultimately our physicians, and in their professional development throughout their careers, they need to not only attain the skills to be able to adequately provide for their communities, but also to take additional courses and additional training to reinforce those skills and keep themselves current to what is best practices.
Thank you, Victor. My next question for the both of you is, how do principles included in the Best Advice Guide resonate or not with your own experience or practices? Shalene, do you want to start?
Yeah, thanks. I think what really speaks to me, I tried this written down in my notes, is in the slide it said, when possible, include family support. And I just like to challenge that and say, whenever possible, we kind of make including a person's natural support systems the default unless there's reason not to, and ensuring there's informed consent given. But the role that family caregivers, other circles of support can provide really can't be underestimated. It's a great resource that we can tap into. So as you're providing support to a person, being able to engage with that circle of care, engage those caregivers, work collaboratively, that goes a huge way towards supporting the person at the center of the model. So really encourage folks to ask those questions around, who else can we get to support you, who else is involved, how do we work collaboratively, and just expanding on that beyond the immediate family support to the caregiver support. Making sure, not making sure, that's a tall order, but if you care for a person living with a mental illness as well as a family member, just having on your radar that there may be mental health needs for the family caregiver as well. This can be an incredibly challenging role, and being able to be mindful of the caregiver requiring additional support as well would be really helpful. So when we have those supports for caregivers, also looking at what resources are available in the community you can refer to through the CMHA, or in my province we have 211. So looking at being aware of what other places can help support this person, because again it takes a whole community we all need to work together to support each other. So involving family caregivers and connecting folks back to community resources is great. That really spoke to me.
Thank you, Shalene. Victor?
Yeah, thanks for this question. It's a good question as well. I mean, I think the one area that I would resonate quite well with me and my own practice is being familiar with community supports and resources. I think I can't stress enough the need to be able to know that, and also whichever community or region that you live in, to develop a bit of a list for yourself. And also probably even more important than developing a list is ensuring that list is up to date and with resources that are still current. And I know, whether it's at the college or at the commission or other organizations, we've all tried to in some ways provide lists and resource lists to our colleagues and our physicians and our communities. But as we all know, making a list is relatively straightforward, but keeping it current is very difficult. But we all know that we need more than just ourselves, whether we are nurses or physicians or social workers. We do need the support of the community and some of the community resources that come with that. So being able to bring in supports, and just like what Shalene was saying in terms of the family, I mean, the family is certainly crucial. I can't highlight that more than that, but being able to bring some of these other resources is critical, because at the end of the day, as a physician, as much as we want to spend a lot of time and being able to of course, be a great listener, our time is finite, and we need to be able to harness some of the other resources that are around us to be able to provide a bit more of a holistic care to the community and our patients.
Thank you, Victor. In terms of when we talk about if you can, I'm sorry, if there is one thing that you can tell family physicians who are considering implementing the recommendations from the guide, what would it be?
I would probably say ensuring that there's a list of supports. I mean, I know I had said that previously before, but I think that's quite crucial and quite important because in every community it's quite different, whether it's provincial or regional resources that are available or the specific Canadian Mental Health Association resources that are available. So I think it's quite important as you as a physician or a nurse practitioner or any healthcare provider to understand what you have access to and what you don't in the community, and ultimately, if the person is in a crisis situation, what resources do you have at your disposal? Is it that they're in a crisis situation and you don't have a choice but to send them to the emergency department for more acute care versus something that you can manage in the community? So I think having a good understanding and a good list of what the community supports are is quite important, just so that at the end of the day, you're not the end of the road in terms of what that patient can access. You also have some supports to help you in caring for that patient.
Thank you, Victor. And we do agree about the importance of resources. And like you've mentioned a bit earlier, we do have a list of those, like the Commission does have a list of resources, and to our best as possible, we try to keep them updated. And like you said, it could be a challenge, but we do encourage healthcare providers in every community to make sure that they know where to best refer patients and families, because it is important. Like it is a teamwork, and it's important to know what's available and how we can best provide help for those that are asking for it. My last question for both of you is around challenges. Would you be able to identify any challenges or even opportunities that are associated with the implementation of the Best Advice Guide? And if you think about challenges, if you can also let us know if you have any kind of solutions that you can imagine that could be helpful to overcome them. So perhaps, Victor, you can start?
Sure. I think probably one challenge that is difficult to get away from is just the time element. I think in many ways one of the resources that is unfortunately finite is time, and part of some of the issues that patients bring, you do need some adequate time to explore and actually to do some active listening and other modalities such as motivational interviewing and things like that to be able to assist in the clinical care. So I think that's part of the importance of having a team around you, being able to access, whether it's nurse practitioners or social workers, to be able to actually extend yourself a bit in terms of the healthcare team and the healthcare services to be able to actually explore some of the issues with patients. So I think that would probably be one challenge. But I mean, on a more pragmatic and positive note, I think all the recommendations there bring enormous opportunity, which we've already spoken about. I mean, certainly the strength-based language, ensuring that families and friends and community are included in the care plan. I think those are enormous. I mean, they sound in many ways fairly self-explanatory, and sometimes you stop and you think, well, why aren't people already doing this? Because it's essentially in many ways, very much common sense. But I think sometimes when it's more explicit like that, it registers a bit in a more of a real way. So I think those recommendations by themselves, all 7 of them, bring enormous opportunity for the way that we operate in terms of our patient medical home and our clinics, and also an opportunity for us to enhance care for our patients. So I think in terms of the opportunities that it brings a lot, and I would encourage certainly our family physician colleagues to review some of those recommendations that are there, but many of these recommendations are applicable to any healthcare provider, whether it be social workers or nurse practitioners, in some ways to enhance their own practices.
Thank you, Victor, for sharing your thoughts. Shalene, do you have any either challenges or opportunities that you can think about?
Yeah, I think one thing that I found personally really helpful is having a written record of what we talked about in the sessions. I think, what my sense is that for many folks, when they go into the doctor and there's a lot of information coming at us, and we leave the room and then it's gone. So the recommendation about co-creating a personalized care plan really spoke to me, being able to get in writing what we had talked about in a session so that we both understood what's the next plan, what's my responsibility, what will happen at the follow-up appointment, so that after the appointment I can reflect on that and make sure that I didn't miss anything. So I found that just a great point, a great tool that we can use to ensure that things don't get kind of lost in translation or forgotten about between appointments.
Thank you, Shalene, for sharing. This wraps up our interview portion of the webinar. Again, thank you so much, Shalene and Victor, for being so transparent and really sharing your perspectives. That was really insightful. What we want to do now is sort of give some time for the audience to ask some questions. So we do want to hear from you, attendees on the line. Again, if you have any questions for either Brandon, Victor, or Shalene, or all three, please submit them through the Q&A. And we welcome any questions, comments on the recommendations. Even if you have any opportunities for knowledge translation or dissemination, please don't hesitate to let me know. All right, so we've received our first question, and this will be a question for Victor. So one of our audience member asked that instead of having physician asking the person or family member to reach out to community support, is it possible for the physician to refer in writing to those community supports? Perhaps even having the resource available. Is this something that would be feasible?
I think it depends on what the resource is. I think certainly there's resources that are self-referral for patients, but then there's, of course, ones that involve the healthcare team. So I think it would definitely depend on what the resource is. And I think whichever resource it may be in terms of community supports, I think it's something that you and the physician and the patient would have to work on together and establish whether this is the right avenue for them. And then depending on who or what the resource may be, what is the best way to access it. So I definitely agree with the question and the proposal that the healthcare team, whether it's a physician or nurse practitioner, definitely should be helpful and being able to facilitate that referral process, however best it is managed.
Thank you so much, Victor. Another question from the audience is, where do we get copies to give to our family doctors? So I know that the resource is available online. We're going to send you through the online box the direct link. Is there a way? We'll send you the link, and we'll make sure to send the link as well in the thank you email so that you have access to that after the webinar. There you go. Thank you, Alan, for sharing the link. So what is So we have received another question. Perhaps, Victor, you can also address this one. One member from the audience wanted to have a bit more information about what exactly does patient medical home means and why is that used?
Sure. So the patient's medical home, we do have our website there, and I see that one of the Q&A participants did upload the patientsmedicalhome.ca. Of course, there's the file that's included, but the actual patient's medical home website is for you to explore and read about as well too. But basically, back about 8 to 9 years ago, we started this journey of looking at the patient's medical home and looking at the way in which family physicians, through their respective healthcare teams, can engage with our patients and the community. So the patient's medical home is essentially our vision for how family practice should look like, not to be prescriptive about how family practice should look like, but based on its own context. So for example, a patient's medical home framework concept in New Brunswick is going to look very different than a similar one in British Columbia versus in Newfoundland, for example. So I think part of it is we look at the best practices of family medicine, whether it be, in this case, the recovery-oriented model, or in using the electronic medical records, best practices in interactions with military families, and all these various domains that are important to family medicine, and we package them within our concept called the patient's medical home. So that's essentially our vision and a framework, but that framework can be applied to multiple different contexts and areas of practice based on region.
Thank you again, Victor. There's a lot of questions coming in. There's also a next one I think that you'll be able to address. Someone from the audience asked if you can speak to the need for continuing education for healthcare professionals with limited budget and time to pay for staff to attend educational events and to replace staff. If you have any comments on that.
So within the College of Family Physicians, we do have a certification requirement that family physicians undergo 250 educational hours or attain 250 educational credits per 5-year cycle. So that is a requirement for maintaining certification at the College of Family Physicians of Canada. I mean, certainly depending on which region you work in, there may or may not be support for continuing professional development activities, be it through potentially financial support or potentially vacation time or some sort of work leave time for you to take some of these opportunities. I think that will vary by region to region. I mean, certainly for those family physicians that are working in solo practices that are not part of an extended team or does not have the support of their regional authority to undergo, it becomes a little bit more challenging. But I think in many cases, the majority of our members do find the time to engage in professional development activities, and it has been a requirement of the college for many, many years for them to do that.
So introduce.
Thank you, Victor. In terms of the comments that we've received, one of from the previous question, one of the attendees mentioned that you know what she was suggesting when she talked about is it possible for family physician to refer to the community is that have a family caregiver to call a local caregiver support organization is not always enough, and usually the caregiver often feels that they don't need help. So is it possible for the career organization to reach out to the caregiver and if there's a way for them to work together?
Oh, that's a shilling here. So is that a tough one? Yeah, I guess what the type player is speaking to is the organization, the family support organization, to reach out to the family carer. and that might be, I could say that might be tricky for the physician to have the contact with the family care organization, relay the information, and then the family care organization to call back. So I think that may depend on the relationship the physician has with the care organization, and if there's a strong relationship there, and if the caregiver gives permission to release that information, that might be helpful. I think it might be what may work in a larger way. That again, we spoke about how important it was to be connected to the community resources. So if our physicians are able to convey to the family what they might be able to expect from contacting an agency. So that it's kind of above and beyond what we normally ask of folks, beyond just giving the phone number, but really encouraging the family caregiver to seek that support. I wonder if that might be that extra push that the family caregiver might need. And again, for physicians to be mindful of the additional levels of stress that family caregivers experience, and to really be mindful of checking in around their mental health as well, and offering support for their mental health. That analogy that you can't care for someone else unless you care for yourself first, and the oxygen mask on the planes and all that. So that's a tricky question, but that may be a way to move forward.
Thank you, Shalene, for addressing that comment. I think we only have time for another last question. So perhaps you can take the next question, Brandon?
Sure. Yeah, so we did receive a bunch of questions from registrants for the webinar, and just one of them I'll very quickly speak to. So there was a question about how do we move people towards recovery, and there are many steps to this. It's a very long process, and that's why we're taking this one step at a time. There are indeed many aspects of the system that need to be tackled, and this necessarily involves working with the different groups, or collaboration certainly with the CFPC and the Collaborative Shared Working Group on Mental Health Care, with family physicians, and helping equip them with the tools needed to practice recovery-oriented care is certainly one of many avenues that are needed to help foster recovery-oriented practice in Canada's mental health and addiction system.
Shalene and Victor, is there anything else that you would like to perhaps add on how to move people towards recovery?
Well, I just want to thank everyone. There's like 60 or 80, or a lot of folks are on the call. I think there's 300 registered. So I just want to thank you all for giving up your hour today to have this conversation with us, and to download the resource guide. And it's so encouraging to me as a family caregiver and as a person with lived experience to see that level of engagement that we have. And kudos to you guys for being all part of this journey with us.
Thank you.
Thank you.
So just to wrap up, as we are nearing 2 o'clock, again, thank you so much, everyone, for joining us. Special thanks to our guest speakers, Shalene and Victor. We appreciate the time that you've given us today. We also wanted to let you know that there's going to be a survey that's going to open up after you leave this webinar. So make sure to give us your comments today. And if there's any questions, additional questions that you would like us to answer, you also have my email on the screen, so you can send us your questions. And again, remember, our slides, as well as the recording, will be online on our website in 2 to 3 weeks. So you can always, again, refer back to the session, or share the sessions with your colleagues, families, and organizations. Again, thank you so much, everybody, for joining us today, and we hope that you'll be downloading the Best Advice Guide, and let us know if you have any questions or anything else.
Thank you.
Thank you again, Victor and Shalene.
Great. Thank you, everybody. Have a wonderful day.
You too. Take care.